Good morning. So, welcome to Who's Cares podcast. I'm up in Aylesbury with Ian, who works with Orion on the shared care record, and we're talking all things shared care record today. So, I'm a big supporter of Orion and the shared care record. I really like what it's trying to do. So, do you want to just break down what it is? Where are we now?
Yep. So, a shared care record in a nutshell is like a layer over health and care information at a regional level. So whether that be at an ICB level in England, or nationally in Northern Ireland, for instance, or more globally we call it a health information exchange. But it's a layer which brings together data from all different health and care settings, so primary care, secondary care, social care, mental health, puts them together in an aggregated view and gives somebody a portal through which they can view their information. So wherever an individual crops up on that spectrum of health and care, people have at their fingertips the information that they need to make the right decisions on that person. So what medications are they on, what conditions do they have, what do I need to know?
And that's all in real time, isn't it? So as the GP puts it on to GP Connect, it goes straight through to the shared care record.
Basically when it becomes part of the GP record, if I view the shared care record elsewhere, I can see it because we use a connection called GP Connect, which is a sort of a national API, which pulls it's federated data, as we call it, right? So it's not
What's
stored in the
federated data for those morons like me?
there's two. So if we're viewing data from multiple different sources, there's two different ways of doing that, right? So one way is to import the data from the other systems, store those in a database and view them, right? That's called persisting the data. But you can only do that on a timed basis, right? So I take an extract of data from system A and put it into system B, and would do that maybe once every 24 hours. Federated data is a way of viewing it in real time from multiple different systems. So essentially when you open the shared care record and say, I want to see Ian's record, right? It calls the other systems that we're connected to and says, show me what you got. Right? And that's
so
a federated view.
Right now.
It is, yeah, exactly. So it would go off to my GP record and say, give me Ian's GP record. And it will be...
I mean, that's a lot of connections, isn't it? So when you talk about all the people that jump onto the shared care record, it's doing a lot of work, isn't it, behind the scenes?
It is doing a lot of work,
You don't think about it like that, do you? Suddenly you just go in, ask all these systems, all this stuff instantly. I mean, that's quite incredible, isn't it?
Yeah, there's a whole lot of activity that goes on behind the scenes in terms of network infrastructure in the NHS. I mean, the danger is that I think normal citizens often think of the NHS as one organisation. They just kind of think it's the NHS, right?
Because that's how it's sold to us, isn't it?
It's
one
right?
big ship.
It's talked about as the NHS is one organisation, but apart from the fact that the NHS neglects things like social care, right? So we're not even talking about social care when we talk about the NHS, but also the NHS, hospital, GP, mental health provider, they're all different. They all have different systems, they all have different ways of recording data.
All have different governance.
Exactly. They have different rules about what you can and can't see, and what different people can and can't see, what you can share, what you can't share. So there's a huge amount of work that goes into sort of pulling these things together.
It's a hell of a journey for you guys, hasn't it? To navigate this.
Yeah.
So I sit in meetings with you sometimes, and I don't really have the gravity of what you've been doing. I mean, we only see this tiny little bit in the conversations, don't we? But now we're talking, it's like, wow, that is quite incredible.
Yeah. And I think, this stems from the fact that, so Orion Health has been around for 30 odd years. Always with a focus on kind of interoperability and integration, from building the original Rhapsody integration engine through to where we are now with shared care records and health information exchanges and digital front doors, right? But we've been working, specifically with the NHS on the interoperability and data sharing problem for 25 odd years through various different guises of how do we solve this problem, whether it was integrated digital care records or LICRAs or then shared care records or what they're called now, which is connecting care records, which I still neglect to call them. I still call them shared care records, but there we are, right? But we've been doing this for a really long time.
And it's quite incredible, isn't it, that 25 years and you're still not there. You're still trying to find your way through the fog to try and get to the ultimate goal, which is almost like a single port of truth by the sounds of it, really.
Yeah. So, I mean, the problem, it's a really thorny problem. It's what I like to call a wicked problem, right? The wicked problems of health. Whether it will ever be solved, I don't know, right? But we bring in standards for data sharing, we bring in sort of mandates about how people should and shouldn't share data. But there is still a bit of a Wild West culture about some of it, that some people can get away with being really protective over how they allow other systems to connect, which can be really challenging. And I get the reasons why, right? It's not nefarious, but it's often not done very well, and it causes problems and it causes silos. But what we're seeing at the moment, there's a couple of really interesting programs that are coming out to early tender right now from NHS England and the DHSC, which are designed to break down a lot of these barriers. So there's an idea of the social care interoperability platform, which is really to bridge that gap between healthcare data and social care data,
which is massively needed, isn't it?
Hugely important, and we're great supporters of that. And then there's of course this view of the single patient record, which is still in embryonic stages of trying to work out what it is, but that represents a monumental shift in the ownership of health information, sort of away from GPs as the arbiter of that, and to the citizen themselves as the owner of their health record.
And that comes with so many different variables of what could happen with that data, doesn't it?
Yeah, because there's a million ways to skin that particular cat, right? But I think it presents us with an opportunity to get closer to what I think the ideal goal is, which were everything to shake out exactly how it could do one day, right, and all the stars aligned, my view is we would have a fully interconnected fabric of health and care data, right? That wasn't particular to one system, wasn't one platform, it was just everything talked to each other the way it should talk to each other, could talk to each other, right? And then as a user, you would surface those data through an appropriate agent, whatever that was. So if I was a citizen looking at my own record, ideally that's the NHS app. Right? I log into the NHS app, and I pull up my record, and I can see what's appropriate for me to see in a way that I can understand it. So here we'd probably layer on some kind of generative AI that summarises the data and tells me in a way that as a non-medically trained person I can understand these data. Right? And then if I'm a GP, I have my own GP system, but I surface all of those data, the full health record. If I'm a hospital clinician, I have a hospital system that surfaces all of that information.
And that's really relevant, isn't it? Because you do only need to see the bits relevant to you, because actually sometimes too much information is dangerous, isn't it?
Yeah, and this is a real challenge with shared care records the way they are at the moment, and not just shared care records, GP records, hospital records, but shared care records particularly, because they aggregate so much data that when you view a record on a person who's, let's say, in their 80s or 90s, has a bunch of comorbidities, has a huge GP record, as well as they've got mental health providers, they've got social care providers, they've got local authorities looking after them, they've got multiple different hospital encounters. Their record is really big. And as much as we aggregate it and try and make it easy to navigate, if you're not in there for something particular that you know where it is, it can be hard. So, we're layering on things like, natural language processing to be able to, if I go into a record and I'm particularly interested in something to do with history of heart attacks or something, I can just type into a search engine in that record, and it can, use some large language model to go in there and pull out unstructured data that is pertinent to my search, right? Because it can be really hard. So when you start to get into the concept of this utopian future that I talk about of a single patient record, it becomes even harder, because we're talking about everything that we know about a person.
I mean, it's incredibly complex. I mean, obviously, you guys have been doing so much on the ETEP at the moment, and even that's a challenge, isn't it? To get all the variables and everything lined up to make it work.
Yeah.
I mean, everyone's got a different opinion, and it's almost impossible to herd those cattle, isn't it?
Yeah. Oh, yeah. You would think so. So the ETEP is a treatment escalation plan. So it's sort of an advanced care planning document, and it was originally a paper document that was agreed at peninsular level, so Devon and Cornwall, to record a person's wishes towards the end of their life. And you would think, right, if you've got an agreed paper template and you want to turn that into a digital form,
Feels really
it should
easy.
be relatively straightforward. But having been around the block a few times in different guises of healthcare systems, I can tell you that turning a paper form into a digital form is not straightforward. Because people look at it and they say, right, I've got a paper form and it's got a bunch of mandatory fields in it. We say, right, we want to take that paper form, we're going to make it digital, and we're going to make all those mandatory fields mandatory.
We're going to try and make it look pretty.
Yeah, try and make it look pretty, but make the same fields mandatory, right? Doesn't work like that, because administrators assume that when someone looks at that paper form, they fill in all the mandatory boxes, right?
But they don't.
They don't. they might do eventually,
Yeah.
but when they're first filling out the form, they fill out what they need to do at that moment in time.
Because they're in a hurry, just got to get it done.
Exactly.
Yeah.
And they don't. And as soon as you do that digitally, you say, right, you've got to fill out these. You cannot get off that digital form until you filled out all the mandatory ones. We've all been there on a website where it says you must fill in this bit, right? It's got a star next to it, and you can't click off that page.
You just have to put dots everywhere just to get through it.
I don't know that. I can't fill that in. So, there is a huge challenge around taking stuff that we've done on paper and making it digital. And one of the big challenges, I think, is that we assume that we should just be doing the things that we're doing, but doing them better because we have digital tools. And my challenge to that is, well, we have digital tools, so should we still be doing the same things, or should we be doing different things?
I like that thinking, because to me, if what you're doing was the right thing now, it would all be fixed.
Yeah.
So let's break it and start fresh sometimes. It's not fit for purpose, otherwise it wouldn't be trying to fix it, would we?
Exactly. And it comes to the right, because I know social care is
it's my passion
to you, right?
Yeah.
And I think still in shared care records, even in the most mature shared care records we have, social care is still a forgotten area, right? We even not far from you, Bristol, the Connecting Care shared care record, which has been live for over 10 years now, fantastically well advanced, and has great social care data in it, but still not everything, and still challenges with care homes as opposed to local authority data. And I think social care has so many of the human factors involved in it. We get caught up in thinking we need to understand the clinical information around a person, and I think in the NHS we're really good at understanding conditions and problems, but we're really not great at understanding the individual that
the bedside manner's missing, isn't it? If I go into hospital for an ailment, the ailment's the ailment. I don't feel very well. When I don't feel very well, I want 2 pillows.
Yeah.
I want my cup of tea before I go to bed. Yeah. All those little things that make me feel comfortable, make me feel like John. That's what I want, and that's what's important to me. Because the nurses will deal with my ailment. Yeah. But when I'm just sat there really uncomfortable, I feel even worse about it, don't I?
Well, exactly. And your stress levels go up if you're feeling like that. And you're feeling isolated, you're feeling unheard, you're feeling
out of
stressed.
control.
Right? Yeah. Precisely. And that is going to have a detrimental effect on how you recover. And what people don't get is these human factors are at least as important as the clinical factors.
Yeah.
We sit there and we say, yes, okay, you've broken your leg. Okay, fine, it's a clinical problem, right? We can fix that. But what else surrounds that? What does that mean that you can't do? Right?
And I think it's all relevant, isn't it? Because there's so many factors that are missing. If you're a person, we're talking about broken legs, if you're a person though that suffers with loneliness, mental health around that, and suddenly you broke your leg and you're isolated, we almost need to put that package in for them before we even leave the hospital. Exactly. We know you're going to be struggling because of your historical issues. Yep. So let's look at that now before you go. But all that's missing, isn't it? Because that's held in social care, quite often.
Exactly.
And what we find in social care, and I'm really keen to see it connect to the single care record, it's just all that missing stuff. The district nurse will phone you up and say, "Oh, I put it on the local authorities record." Well, that's useless. We can't see that.
Yeah.
So we're often running blind. But in the same way, if an ambulance picks up my client, they're running blind. They won't access our DSCR. Yeah. They'll just go, we're going to pick them up, and with the old data, take our file. They haven't got their file there, so you just go, okay, well, we don't know which agency they're with, which is going to take them to hospital. Don't know what medication they've had. They don't know what they've had for the last week. Don't know if they've had a UTI. Don't know what their baseline is. Yeah. And it feels like a completely crazy situation with all these incredible digital solutions that just don't talk.
Yeah.
But that's where you're trying to come in, isn't it? And that's the aspiration, to bring that together.
For sure, it's the primary problem that we're trying to solve, is to make sure that the things we know about the person, everybody knows.
Yeah.
If they need to, and they have a reason to, right? And that includes those human factors, because they are really important. Because for a lot of people, especially, you know, we talk about frailty and dementia and things like that, right? A lot of the high intensity service users, the people who are consuming the most health and care resources, are the ones who are frail. And a lot of the ones who are frail are suffering with, you know, some kind of detrimental effect mentally. And not doing those things that keep that person feeling like themselves really cause problems with being able to do the actual clinical treatment. If we, you know, if we don't know that, so my grandfather, right, for instance, his name was Alfred Paul Binks, right, but he liked to be called Paul. He never used the word Alfred, but if somebody just looked at his medical record, they'd call him Alfred.
And he'd
like, who the hell's Alfred?
He'll ignore it, yeah.
But you know, when he was like deteriorating with dementia, he wouldn't even know that Alfred was his name, because he was never called Alfred.
But I mean, we hear that all the time. I mean, I've had some real callers in my life where it's not even their name; they just call something different. You know, it might be the name's John, but actually go there and no, I'm Fred.
Yeah.
And it's just what the nickname was as a child.
Because they've been called it since they were 5.
Yeah, and it's all those things that completely get missed, isn't it? I totally agree with that, and I think that there must be something as a sector we can do to push that forward more.
Yeah.
And I don't think it's just necessarily the NHS that need to do that. I think as a whole sector we need to go, actually, this what about me?
Yeah.
It's really important to share that somehow.
Yeah.
And it's really tricky with our silo digital records.
Yeah.
How do we get through that? It's another conversation for another day, isn't it? But I think it's about taking some responsibility as the people that provide that care.
But yeah, it is. It's potentially a conversation for another day. But like, it's stuff that we're working on right now, right?
Yeah.
I mean, you know, we've done the TEP in the shared care record in Devon and Cornwall. But one of the things that we're working on very closely with Devon and Cornwall, being led by them actually clinically, is the creation of an integrated digital care plan that sits in the shared care record, which is the stuff that spreads across all kind of different aspects of care. So the treatment escalation plan is an advanced care planning thing, but things like a comprehensive geriatric assessment, things like frailty scales, but importantly, things like about me, right? The stuff that a person...
So Jane sent me all those triggers of the week. She said, can you just look at all the places where social care meets, please?
Yeah.
What information do you want? And I haven't done it yet, so sorry, Jane, if you're listening. But I will do it. Because I think there's something really fundamental about the co-design here, isn't it? About what's important for me to share to you that I feel is really relevant.
Exactly.
Because we're not all experts in each area. And that's what I like about Devon, because they are trying to pull people in to co-design this, aren't they?
Yeah, exactly. And this co-design is massively important, because one, what do I want you to know that our system knows that we know that you don't, right? And two, what do I need to know from you that helps me do my job, right? And that's why we get everybody together. But the key is going to be, if we can accelerate the program of integration with the NHS app, so if we can get the NHS app team to open up the right bits of the app for us to push data into, then suddenly you've got this whole integrated care planning solution in the NHS app. So I, as a citizen, if I was working for myself or as a proxy for somebody who I was caring for, we've got that whole care plan. We've got the ability to update it from the app. So if I want to change the about me, I can change it. I can update those things, because these are non-clinical data, right? These are stuff that a person can contribute to without worrying about it, you know, corrupting the medical record. This is stuff that I need you to know about me or
change,
my loved one. Yeah.
You know, you might be watching EastEnders and a cup of tea on Monday and think that's fine, but you know what? When you go into hospital, you suddenly go, actually, I want to watch Netflix, please. You know, whatever that feels like.
Yeah.
I think that's a really interesting place to be. I mean, is that likely to come anytime soon, do you think?
I mean, it shouldn't be too far off, right? But it's when how long's a piece of string, right? But I think this whole concept of really opening up the NHS app's integration capabilities is fundamental to the desire to build a single patient record and to have people taking more ownership of their own health and care information. So as a supplier, you know, we've done a whole chunk of work in the background for that integration to happen. We still got more work to do if NHS England can say to us, yep, right, there's a jump off point in the app now. You can surface your integrated care plan, give us a single page app that is exactly like the NHS app, because that's how the NHS app works, right? It's not all one application. No. It's lots of different applications, but they're supposed to look the same.
Yeah, so just pulls it through, so the user has no.
So as a user interacting with it, I don't notice that I've come out of the NHS app and into Orion Health, and it should be seamless. But we just need some jump off points in the app. Really.
Well, I mean, and that will come out if you like you say. I mean, I'm just going to touch on the last bit then before we disappear off, really. So, you've been working a lot on this GP Connect we spoke about earlier, and we also know that all the digital social care records, if they wanted to be registered on their portal, had to integrate with that so we can view it. I mean, how far away do you think it'll be for this interoperability stuff to work so I can pump information into your record? How far away is that? Years, 10 years, 5 years? Because I mean, it's after this conversation, you suddenly start going, this is really complicated. Because me and my little brain going, oh, just connect it.
Yeah, exactly. Just plug it in. No, so look, so there's a bunch of different mechanisms in play there that kind of get us steps of the way rather than it's not just one leap. Which is a good thing, right? Because if it was just one leap, it could be too far and it could be a long way away, right? But there are steps that can be taken. So on the sort of digital social care systems, there's a few suppliers out there that make really, that have most of the market, so person-centered software, Nourish, right?
All those sort of things.
Yeah, exactly.
Other ones are available.
Other social care systems are available. Those are two that we've worked directly with quite closely, and we want to work with anybody who's building those systems, but we can integrate directly with those systems, and we're doing work with those providers to pull data from those social care systems into the shared care record. So that's step one.
So that's really good learning, isn't it?
Yeah, and that's relatively straightforward, right? Yeah. Because it's a digital system linking to a digital system. We just need kind of standards of what data are you asking us to ingest,
and where does it go?
What mechanism are you going to send it to us by? What do we then need to do with it? Because sometimes when we get lots of different data into the shared care record, we have to do things like deduplicating things, right? Yeah. So you don't have the same thing appearing multiple times in the record.
And do you struggle a lot with language? So what it's called here isn't called there, and stuff like that, because we're all so different in the systems, aren't we?
So there's a concept called like a terminology server, right, which ultimately takes things that are called different things but are the same thing, and makes them the one thing in the shared care record, right? So that's the simple way of putting it, and that's mostly
that's not complicated at all, is it?
It's mostly because I run out of intellectual runway on the technical side of things, right? But terminology servers are designed to make sure that the terminology is the same, right, so that people can understand it. But we do have the same thing will be called different things in different systems, and we need to match those, and we need to decide, right? Then there's a decision to be made of what's it displayed as in the shared care record, right? Yeah. Is it version A, version B, version C? Right? But you have to make it one thing. You don't display all three versions because you're getting three different versions. Yeah, so complex, right? Step 2 of the whole social care thing is the social care interoperability platform, right? The SCIP program that's out for tender at the moment.
Yeah.
If that comes to fruition, whether it's whether we're successful in our bid for it or somebody else or multiple providers do it, right? Then you have essentially it's a brokerage platform that sits between health data and social care data.
Yeah.
And it means that in the social care systems, you will have all of the health data passed from things like GP Connect, National Record Locator Service, Patient Demographic Service. All of those things can be passed through this brokerage into the social care systems. So the social care end, you'll see all of the health information you need to see.
Yeah.
But that doesn't push data the other way into shared care records. That's not the purpose of it.
No. It's going to be interesting times, mate, isn't it? A lot of work ahead of us all as a collective, really. Yeah. I think, quite often we see, well, as I know you guys, I see Orion going, oh, you guys got all that to get on with. But actually, when you have a conversation, you suddenly realise the responsibility is for the sector to come together to make it right, isn't it? Yeah. No one person can do it, no one company can do it. And especially when SCIP comes in, there's going to be lots of conversations with social care going, what is the right data and where does it go?
Exactly, and this is why I look at things like the single patient record tender, and we're being asked to weigh in at the market engagement of like, what recommendations do we have, what do we think the right solution is, and my first point is that do not assume that one supplier can provide this. This is not an FDP that you can go to tender and award it to one company and expect them to do it. The way to do this is to make sure that we properly standardise the way systems talk to each other, and we just start to remove those barriers between systems and get them talking to each other.
And that's the real key then, isn't it? The basic infrastructure, fix that before we start building on it, really.
Yeah.
Because at the moment it's very left and right, isn't it?
It is, and because systems have evolved in different ways, and that's fine, right? And some companies have taken a very protectionist approach to the way they deal with their data. Some companies have taken a very open approach. Some are somewhere in the middle, right? And what you've got is this mixed infrastructure of how do we record and how do we integrate health and care data. We need to level that. Right? It needs to be kind
That's
of
a really
the
common
same
sense approach, isn't it?
Yeah.
It's a bit like the charger's Rappel now, isn't it? Everyone's got the same charger, and I mean, it makes perfect sense, doesn't it?
Precisely. Go from everyone's got a different plug that looks differently to flat USB-C. Everybody gets a USB-C one, and then it's all good. And it's not easy because for some companies it's a big jump, right? And it's it needs to be a program like the single patient record, which is a funded program from the government to say we're going to help you get where you need to get to. Now GP Connect was a massive development for us, right? What would have been good is if the government had just funded all the suppliers, or NHSE had funded all the suppliers or whatever, to just develop against GP Connect. We had to eat that cost, but it means that we now have an integration that works with GP Connect. But I think if you're going to say everyone's got to standardise the way they record and send data.
So I find it really funny though, because again, in my very small technical brain, I always thought they missed a trick with the SDR providers to go GP Connect, not just go single care record. So I don't know how many single care records there are in the UK, but actually, would it not have been easier just to get everyone to connect straight to single care records and start that process?
Well, yeah, so there's, in terms of suppliers of shared care records, there's 7 of us, right? But a couple of them have only one shared care record in their little pocket. So, properly integrating with the shared care record providers would probably be a really straightforward way of doing it. The integration with GP Connect means you can pull a GP record, but you can't pull anything else. Yeah. Right? You can't pull community data.
So that's what I always found really funny, because I was just like, well, surely it makes sense just to go straight in for the jugular and have access to deliver in and take out.
Because once you integrate with the shared care record, you can pull all of those data, so hospital data, mental health data, community data, GP data. Right?
And long term, probably would have been cheaper because they would have needed skip.
True.
So it is what it is, isn't it?
But there we go, yeah.
There you go. Listen, mate, I think that's enough for today. It's been a pleasure to come and meet you personally at last, and
just making the journey. I know it was an early start.
5 a.m. I left my house, but my mum lives close by, so I'm going to see my mum in a minute, and it will be great. So, but I think it's just really important to get this conversation done. I've been following Shared Care Record. You can pop in now and out of meetings. I don't attend all of them because a lot of it's way above my head. I'm on the social care side, and I'm sort of waiting for that moment where I come in and go, right, let's just do it now, because we're not quite there yet. Yeah. But if you ever need any help for that, you can always give me a call. You've got my number, and we can always try and help. Listen,
I appreciate it, mate.
Thank you, mate.
It's been a pleasure.
Yeah, we're going to go to the claps for you, mate.
Cheers.